Hey, good morning, everyone. Let me know if you can hear me okay. Perfect. Morning, all. How was the exam? Hopefully not too bad. Good. That's a adjective I don't hear often for my tests, so that's a good sign. Or just being kind, by the way. Behind the scenes, I'm sure there's plenty of expletives being to describe my test, but that's okay. Oh, I hope they're fair. We'll get started in just a few minutes. Of course, I will have to review the stats and everything to see if there's any givebacks or missed keys or anything like that, and then uh, talk about any high misses and stuff. And of course, if you have any questions, you can post them up either here in chat or be a few stragglers, but probably go ahead and get started here. Or let's see. All right, so I got the recording going here, and we'll go ahead and get started. You can see I posted up on the site here that I did post the first two PowerPoints of the next section. We'll cover these first and then get into the cardio stuff, so I'll upload those when we get closer to it. Anywho, I hope the test was okay. I hope it went well. Honestly, there's no cumulative correct. Kind of upset. I knew all about prostaglandin side effects. Yeah, there's no cumulative test unless you guys really want there to be one. But no. Otherwise, some of these things still come up though, right? So you may still find side effects of other drugs if they interact with stuff we're talking about can still come up. So like the antibiotics, they're going to be present everywhere, right? So that's you still got to know that stuff. So not cumulative in the sense of what you're thinking. Like I'm not going to put optho questions or derm questions on the last exam or something, but the stuff does come up from time to time. So it is what it is. Anywho, it sounds like I'll take Josh as being representative of the rest of the class, and I will not have a cumulative. How about that? Good. So let's get started. Let's talk about the ENT and some dental, not really so much on the dental side. It's mainly going to focus on the ENT side of things here with some antibiotics and things like that. Starting off, I want to talk about otitis media. This is a pretty common complaint, especially in children. We see this in the PEDR all the time, certainly urgent cares and other places. But um, again, we learned a lot about the antibiotics, and I want to talk more specifically about how we can use them for these different kind of specific indications here. So when we're looking at, say, for instance, you're working in the ER and you have it on the board, it says, hey, there's a 4-year-old ear pain, right? Just off of that, you don't have to see the patient. You're already coming up with like a differential in your mind of what the patient could have going on, right? And so when you kind of land on it being an infectious cause, you also want to come up with sort of a differential of like what's the causative organism there too. In a lot of cases it's viral, but there is a high propensity for it to be, maybe a co-infection with some bacteria and whatnot. And so you got to know what bugs could be there in order to have a good idea for what type of drugs you want to use to cover that, right? So that's really important for you guys to be able to figure that out. And so again, common things are common, and this is where you're going to be able to come up with this stuff in terms of like what your common bugs are going to be for a given disease state. And so for most of the upper respiratory stuff we're going to be looking at, it's going to be strep pneumo, H. influenza, and then Moraxella catarrhalis. Those are sort of the three most common upper respiratory bugs that can certainly cause infection in the lower respiratory tract and elsewhere, but for URIs, this is going to be it. And so we certainly see this for the otitis media. We're going to see this with sinusitis as well in just a little bit here. And of course, things can change over time as vaccines become available or become more or less commonly used. So for instance, like H. influenza, we do have a vaccine against that, so it does help kind of reduce rates over time. What are we going to do for these patients here? I'm not going to ask you specifics on dosing. As you probably have seen on the last test, I didn't do that. I'm not going to do that here. But certainly I'd like you to know sort of like what's your go-to drug, what are your backup drugs, if you have an allergy, what do you use as a second line? Those are the things I want you to kind of know about this. So with otitis media, for the majority of patients, you can get away with just using like some high dose amoxicillin. We go for higher doses than normal because of strep pneumo resistance does become an issue, especially depending on where you're at and what the kind of local resistance patterns are. If it's not, if they have really severe disease, or maybe they've had history of, maybe they were on amoxicillin recently because these kids can have recurrent ear infections. This is where you can bump it up and use something like amoxicillin clavulanic acid, right? So remember, if we are adding in a beta-lactamase inhibitor, that's really helpful to overcome a lot of those resistance rates for things like strep pneumo and whatnot. So that can be a useful sort of a second line there. Yes, good morning. If you're coming in late, you can always back up the stream and watch it from the beginning. So I don't want anyone to think that I'm leaving them behind by any means. So fortunately, YouTube has that ability. If you had someone who had a real penicillin allergy, like history of like wheezing, rash, and or anaphylaxis, that's could be something where you don't want to re-challenge that with penicillin. And so something like ceftonir, Etherdrin, cephalosporin, or azithromycin can be useful here. And again, you have to kind of know what the resistance rates are like in your area, because for instance, azithro might not be a good choice because if you have a high propensity of resistant bugs, then maybe going with Etherdrin, cephalosporin is a better option there. Just really depends on the situation. And then for some patients, if they fail therapy and they've been on antibiotics for 3 days and it's just not getting any better, that's where we can consider doing something like IM or IV therapy, but we like to hold off on this if we can. And again, using a parenteral, Etherdrin, cephalosporin just gets higher systemic concentrations and is more likely to eradicate that infection. Because it can be a little bit difficult to penetrate that middle ear, especially if like eustachian tube is all clogged up and everything is just kind of being held in there. So that can be a challenge for sure. So switching gears and talking about bacterial rhinosinusitis, you can see here that's the same, bacterial spectrum in terms of, or similar as otitis media here, but you may see some additional bugs also causing disease. And so that's going to lead us to changing up the antibiotic selection here a little bit. So for instance, like strep pyogenes, Staph aureus, and some gram-negative bacilli can actually start to be positive for rhinosinusitis. Keep in mind though, that like the majority of patients, like if they're coming in complaining of, sinus pain and mild fever and things like that, depending on the time frame for how long they've had symptoms, it's probably viral in a lot of cases here. They have to have like symptoms more than like 10 days before we really start to think that it's going to be bacterial. And so once you have that sort of history, it's been like greater than 10 days of symptoms and they've been worsening after like 5 or 6 days, that's where you can start, be reasonably sure it's going to be bacterial and go ahead and start antibiotics. So here, instead of going with just straight up amoxicillin, that's oftentimes not going to be sufficient for these patients here. So we want to go ahead and start with something like Augmentin. Using a beta-lactamase inhibitor is going to be really helpful for more resistant strains of H. influenza. So that's why we go ahead and start out with that. And then as an alternative, if they had a penicillin allergy, this is where we can use something like a combination of clindamycin plus cefixime, right? So what's that going to do for us in terms of coverage? Well, clindamycin is going to be able to get all that gram-positive bugs that could be there. If staph was there, you can certainly get that. Plus cefixime, third-gen cephalosporin is going to get some additional coverage in terms of gram-negatives and things like that. So you could use that combo, or you could use something like a fluoroquinolone by itself. But remember, fluoroquinolone's resistance patterns are a bit of a challenge, and so if you can hold off on using this, especially if it's like a kid, because of the tendon issues and things like that, you may want to avoid that if you can. However, using 2 drugs instead of 1 is also negative from a compliance standpoint. So either way, it's not really an ideal situation, but you kind of go with whatever is reasonable for you and the patient, right? Going to pharyngitis, this is where we can see this is mainly going to be either viral or just group A beta hemolytic strep here. You can see about a third of cases will be caused by that organism. A lot of times, though, we don't really care about the strep infection itself. I mean, some people are just carriers and they just are colonized with it. It's more so the rheumatic fever and some of these other suppurative complications of the disease that we really are worried about. We don't want someone to get like rheumatic fever and have heart valve issues and things like that. So this is why we go ahead and treat these. And so it's very easy to overprescribe for this because you hear someone's got a sore throat, give them some amoxicillin, send them on their way, right? They feel better after a couple of days anyway because it was viral, and they like you because you gave them a script. Not great. What we do instead is we do like a rapid strep test to go ahead and see do we detect the microorganism there. You also do a backup culture because sometimes the rapid strep will give you a false negative. And then if they show positive on the rapid strep, you go ahead and give them amoxicillin. That's typically our go-to, and that's sufficient enough to go ahead and kind of manage that and prevent those secondary complications of strep pharyngitis. That's why we do that. If you had someone who's like not really going to tolerate oral meds, that is where something like benzathine penicillin G, just a one-time IM dose, can be beneficial. And you may ask, like, why don't we just do that for everyone? Well, it's it could be traumatic, especially for kids who are getting a shot. It could be painful. It's, you don't have to do that. You don't want to. But also giving kid meds for 10 days is also a challenge as well. So as with everything, there's pluses and minuses on either side there. If you do have someone who could not tolerate penicillins due to allergy, this is where you can have something like first-gen cephalosporin is fine here, clindamycin, azithro, any of these are reasonable to use for this particular condition. All right. We'll talk a little bit about some otic antibiotics you're going to run into. Now think about someone who has like otitis externa or something where they have a bacterial component to the disease for sure, but then there's also this really strong inflammatory component causing a lot of swelling, and it's really painful, and the ears just super hot and just uncomfortable for the patient. So most of the time you're going to see these otic antibiotics actually mix 2 drugs together. Typically it'll be an antibiotic plus a corticosteroid. Steroid is there to try to provide anti-inflammatory actions, help with the swelling, will help to open up the ear a little bit, help with the pain, things like that, while the antibiotic kind of does its thing. So what do we normally see here? Either things like a fluoroquinolone by itself, most frequently, so something like ciprofloxacin or ofloxacin by itself. A common one we see prescribed quite a lot is going to be Ciprodex, which is ciprofloxacin and dexamethasone. This is pretty costly though, so you're going to find some patients may not be able to afford this, especially based on their insurance. And so because of that, we may want to go with alternative agents here. Even though it's a pretty convenient, really good drug, it's just expensive. Sometimes what we'll do is actually use something like ofloxacin, otic drops, and then we'll actually prescribe the patient as well some dexamethasone ophthalmic drops. And so one caveat to note there is you can use ophthalmic drops in the ear. That's totally fine. The ear doesn't mind, but never use otic drops or anything in the eye. It's just not formulated for that. It's, the pH is off, the tonicity is off. It's just not great. So there's that. An alternative to something like Ciprodex could be something like neomycin, polymyxin B, and hydrocortisone, so otherwise known as cortisporin. Neomycin being an aminoglycoside like gentamicin and tobramycin. Polymyxin B, sort of, we talked about that in Derm, I believe, where we talked about it being sort of a cell wall active drug. You know, we don't typically use it systemically because it's really toxic, but if you're using it, you know, in the ear, if you're using it on the skin, not really a big deal, and it's really good at killing the bacteria. And then the hydrocortisone as the steroid there in that combination. One thing to note here, and again, you know, when we use these, otitis externa is probably the most common reason for that. Sometimes otitis media, especially if they've had like a you know, TM rupture or something like that, so occasionally we'll use it for that because it's able to get there and get nice local concentrations. There are some notes here that I want you to make note of, so that way you don't use the wrong meds for the wrong patients here. So one thing you'll know is that if a patient is going to have a sort of a dermatitis-like reaction to one of these drugs, it's probably going to be neomycin. So look out if they have a history of bad reaction to neomycin, if they have an allergy, maybe something you want to avoid, or at least warn them, hey, if you start to notice that, you know, it feels like the inflammation is getting worse after you do the drops, and it could be related to that, right? Polymyxin B, you do not want to use for patients with a ruptured TM or if they have like tubes in place. The reason for that is because polymyxin B is fairly toxic to the hair cells and the cochlea. So if you were to have that sort of open TM, the drug could really get in there into the inner ear and could cause you know, damage to those hair cells and can actually lead to hearing loss, which you obviously don't want to do. So you'd skip polymyxin B if they had a ruptured TM, which you'd be able to see on exam. But as I mentioned, Ciprodex is expensive, so you can use that alternative of the 2 separate drops if need be. All right. I do want to talk about a few systemic antiviral agents here you may see used for ENT purposes. So starting out, we see for herpes virus, we do have some agents available to us, and a lot of the drugs we'll see used for this also have some activity against things like varicella and cytomegalovirus. So you'll see some similar drugs used for those cases there. I'll mainly focus on the varicella and the herpes for our purposes today. You know, with herpes simplex, there's type 1, type 2. You know, you can see here that, you know, they don't always cause the same infections in the same area. Sometimes you can see they can kind of switch around. You can have type 2 up on the face and vice versa. But again, we're talking about like cold sores and things like that. The way these drugs work that we're going to talk about right now is acyclovir and valacyclovir. These are 2 kind of the most common antiviral agents for things like herpes and varicella that you're going to run into. And these are what we call guanine analogs. And so why do we call them guanine analogs? Well, because they look kind of like guanine, like you would normally find in viral DNA, right, in RNA. And so these are what we call chain terminators. And so what that means is basically this looks just like a nucleotide. It looks just like guanine to the virus. And so it tries to incorporate it into its DNA. And once it does that, there's no sugar backbone here like you would see with a normal nucleotide. And so basically the virus can't add on any more bases to it. So if it can't add on anything else to it, then basically it stops the DNA from being replicated. And at a point, once you've caused enough damage because you can't replicate that DNA any further, the virus just kind of offs itself. You know, apoptosis takes place. So that's how we do that. It kind of prevents the virus from replicating. It doesn't directly kill it off. It just kind of prevents it from being able to produce that new DNA. The relationship between these 2 drugs is that valacyclovir is actually a prodrug. So this is not the active form. It has to be turned into acyclovir. The reason why we do that is because it actually helps out a lot with bioavailability, meaning that you require less drug in order to get the same systemic levels, which can be a benefit. And so this is kind of talking about the same thing I mentioned there in terms of its effects on its mechanism of preventing that elongation of the DNA, commonly called those chain terminators, right? So we'll see that a lot actually in cancer drugs a little bit later too. But anyway, so we can use this for herpes simplex, varicella, you know, people with shingles. You can use this for cold sores, a lot of other indications too. You can have things like, you know, herpes, meningitis, and, you know, things like that. Can't see resistance. So there's some other agents you might see used occasionally, but kind of outside of our scope for today. And just know that valacyclovir is a prodrug. So you would just see that the bioavailability is much better with this drug than it would be with acyclovir. Now, if I had someone who required like IV therapy because they either couldn't take oral or they had some more systemic viral infection, this is where you'd use, if you had to use IV, it would be acyclovir, right? Because if I gave valacyclovir IV, 1, it's not available, and then 2, it wouldn't be active. It has to go through the liver first to be activated. So it really wouldn't make a lot of good sense there. So But Valacyclovir is a newer drug. It is likely to be more expensive than Acyclovir, which is been around for a long time, so it's relatively cheap. So adverse effects wise, these aren't the best drugs, and so you do want to make sure you educate patients on some of the things to watch out for. One of the big ones I'll say here is just to maintain good hydration, which may be difficult, especially depending on how the disease is manifesting. If they're having any kind of like stomatitis and are unable to swallow effectively, things like that can make it difficult, but you got to make sure to maintain hydration. The reason for that is because depending on the concentration of the drug in the kidneys, and depending on things like pH, you can see that it has a tendency to crystallize out, right? Precipitate out of solution and form these little crystals of acyclovir and can cause interstitial injury to the cells, right? So imagine those little crystals poking into your cells and lysing them. Not great. So we help to prevent that by maintaining good hydration for those patients and just have good oral PO intake, and then that helps to kind of flush the kidneys out and prevents the acyclovir from crystallizing. That's the main thing you want to educate on. The other thing to watch out for is going to be, especially in elderly patients who may have pre-existing delirium and things like that. This is where, or dementia, I should say, this is where you worry about the CNS toxicity. So especially, you can end up seeing some altered mental status associated with this. If they have poor kidney function, they have high levels of acyclovir building up, then you got to watch for seizures as well. And then just like it inhibits the DNA of viruses from replicating, it can actually do that to our cells as well. It's not perfectly specific for the virus. And so it can actually affect some of our bone marrow and actually suppress that. And so it can actually lead to things like, compromisation. This is less likely to happen. This is more so seen in patients who, maybe had a recent bone marrow transplant or something, who are immunosuppressives, or, there's specific situations. But for majority of patients, it's not going to be too big of an issue. Just make sure they're maintaining good hydration there. Also, this is a good general caveat for most antiviral drugs, is that the sooner you can start it, the better. Basically, if you have someone who has, for instance, a cold sore that starts, or having some kind of outbreak of herpes or varicella, if you start it too late, like, say 24 to 48 hours after symptom onset, it doesn't really do much. It doesn't really help out with symptom severity, doesn't cut down on the time of the illness or anything like that. So you really got to get it in there early. So as soon as they know symptoms are happening, this is where you can start within 24 hours. That's where you're going to get the most bang for your buck. So one thing to note with that is it always asks questions about when the symptoms started, because that can lead you to either choosing to treat or not at all, right? Okay. Switching gears, let's talk about some ENT anti-inflammatory drugs. So this is going to be like the typical, like, patients coming in with the sniffles and mild fever and all these kind of things. This is kind of the drugs I want to get into. A lot of these we're going to talk about will be kind of over-the-counter meds that patients may be self-medicating with. And so you always want to make sure when they come to see you that you get a good idea of what they've been using already to treat their disease, how much they've been using, because maybe they're using too much or too little. These are the questions you want to ask for those patients. Anyway, let's talk about salicylates briefly here. I've mentioned aspirin before, but again, this is one, very old drug. Comes from the bark of a willow tree, where we get salicylates originally. And so it is basically working irreversibly to inhibit cyclooxygenase. And so, part about it, I won't sneeze. Okay. Anyway, so this is going to be an irreversible inhibitor of cyclooxygenase. Cyclooxygenase being an enzyme that's responsible for producing prostaglandins, and prostaglandins are really powerful inflammatory cytokines that cause fever. They cause inflammation. We're also going to see when we talk about this in terms of the cardiology drugs and hematology, this will come up again, because I'm sure most people know for heart protection, you use baby aspirin a day. We can also use it for its anti-inflammatory properties and antipyretic properties as well, for people who have mild fevers or at home or something like that. We're going to find that at lower doses, typically you're going to get mainly just antiplatelet effects, and of course with that you're going to be worrying about bleeding and bruising and things like that. Obviously, the doses we're talking about here in terms of use as an antipyretic or analgesic are typically going to be somewhere more like closer to 650 to a gram kind of range there. So someone taking like a baby aspirin for fever is probably not going to cut it for most adult patients. That's why you want to ask, well, how much did you take? And that may lead you to see whether that was an effective dose or not. Aspirin's not great, and you probably won't see it used a lot for a lot of over-the-counter stuff. You probably won't see it used a lot in hospitals unless it's for a specific cardiac condition, because it is not doesn't have as good of a safety profile as something like some of our other NSAIDs, as we'll see here in a little bit. And you can see what can happen with higher and higher doses of aspirin. It can be pretty dangerous. Not that most of your patients will get doses like this, but I just kind of make mention of it here because we're going to see that the safety profile of things like NSAIDs are typically a little bit better than aspirin. Obviously, if they already have, a bleeding disorder, this would be contraindicated. Probably want to avoid this in most cases of pregnancy, even though there may be some special uses for it, but I'm not really going to quiz you on that by any means. And then this is a big one here. You want to really make sure that kids who have viral disease, like chickenpox or influenza or something like that, make sure that they don't receive aspirin, or that you educate the parents not to give them aspirin, because there is an increased risk of something called Ray's syndrome that can happen. And this is specific just with salicylates, okay? And so basically what happens is they get this fatty liver encephalopathy that can develop. And again, I don't know the mechanism. I don't know if anyone really has a full idea of the mechanism, but basically it's usually kids less than 16 that this can happen in. And if you don't catch it and manage it early with good supportive care, it has like a 50% mortality. So it's really quite dangerous. And you can see here how, kids got a viral illness, they got mild fever, the parents are giving them aspirin, and they start having things like vomiting, and they're kind of lethargic, and just not acting right. Like, a lot of that looks like progression of that viral disease, when actually it's this Ray's syndrome taking place here. And so they can develop pretty significant CNS injury, hepatic injury, all these things here. So really make sure they're avoiding anything that contains salicylates for kids less than 16, especially if they've had any kind of viral illness. I just say, as a general rule, just don't give them aspirin unless you have a really good indication to do it, like Kawasaki's disease, or they've had open heart surgery, something like that, right? If you're going to use it, you're gonna be in a specialty where you know why you're using it for the most part there. Otherwise, if you're just like family practice or more general practice, like just avoid it in kids. It's easier that way. Now, what you could use instead would be something like ibuprofen or Motrin. And again, most people probably have this in their cabinets at home. Most people have probably taken this. Again, this has the same mechanism as aspirin, but we're going to see that the safety profile is going to be a little bit better for the most part. Which is funny because, anyone can go buy, a gallon's worth of aspirin over the counter, no problem. So it's kind of interesting, the things that are over the counter that can be quite dangerous versus, things that we keep as a prescription only that are relatively benign. But, it is what it is. A lot of those old drugs got grandfathered into certain laws, and that's kind of why the way things are. But anyway, looking at our NSAIDs here, again, they're going to be providing good anti-inflammatory, analgesic, and antipyretic effect. The same mechanism is going to be seen here. They're blocking the activity of cyclooxygenase, otherwise known as COX-1 and 2. So there are two varieties of the enzyme. We'll talk more about the differences between those when we talk more about like pain management next semester, I believe. And so anyway, again, we're using it for mild fever, mild to moderate pain, things like that. Typically avoid in pregnancy if you can. We'll talk about the kind of safest drug for pregnant patients in a moment here. And ask patients, like, how much have they been using themselves at home? How often have they been dosing? Because a lot of people do this incorrectly. Using too much, too little, too often, not often enough. It just depends. So you want to try to nip that in the bud if you can by figuring out what they're doing at home. Now, especially if they're kind of chronically dosing themselves pretty heavily and taking it, chronically for a while, we do run the risk of things like gastrointestinal ulcers that can develop here, which can progress into things like perforations, bleeding, and whatnot. You do want to be careful with that. This has to do with prostaglandins being really necessary to help form that protective barrier in the stomach that kind of prevents our stomach from digesting itself. And when you give COX inhibitors like an NSAID or aspirin, you can actually start to decrease that barrier, and then the acid can erode through that barrier, eventually start to digest the stomach. And so that's where you can run into ulcers. And in fact, if you have someone who has a gastric or duodenal ulcer, it's very likely due to an NSAID, or if not, then it's very likely due to H. pylori. Those are kind of the two big causes of why we worry about gastric ulcers. You will see that for patients who have things like CHF, or for instance, if they have hypertension, typically NSAIDs can worsen this, and it has to do with their effects in the kidneys. And so I can show you why that is in just a moment here. This is kind of a good one because this will come up again when we get into talking about cardio stuff here. So if you guys recall your renal physiology, if you remember what the nephron sort of looks like, If you recall, you know, there's blood flow coming into the nephron. You can see here's the glomerulus we're going to run into. And again, you guys are lucky you get to see my amazing art skills here. And here's where the actual filtrate happens here. So we got another. Very good. Anyway, so point being is that, you know, we're going to have blood flow coming in this direction and blood flow heading out this direction. And then the filtrate is actually going down this direction here, right? Where the urine's actually being made. So what you're going to find is that we have different chemicals in the body that are able to regulate how dilated or constricted these vessels are. This is called the afferent arterial. Afferent because it's heading into the glomerulus, and then the efferent arterial heading out, right? I think effervescent, efferent heading away from. And so there's different things that can affect this. So for instance, when we get into talking about like cardiology, we'll see like angiotensin 2 is really important here, right? Again, I'm left-handed using a mouse on my right hand, so this is probably better my normal handwriting, to be honest. But anyway, so angiotensin 2 is really important for affecting the efferent arterial, but prostaglandins are actually really important for the afferent arterial. And normally what they do is actually cause a vasodilatory effect. So they actually open this up, okay? Which means more flow comes in here, which means more filtration happens. Well, what would happen if I gave an NSAID and got rid of that? Well, basically this would be shut down, and instead the vessels would then start to narrow, right? So then instead of being like this, perhaps it would then, you know, maybe only be this big, right? And so what that does is it limits the amount of blood flow coming into the glomerulus, and the kidneys can detect that. They're like, hey, wait a second, there's not enough actual flow going on here. We need to do something about that. And so what does kidneys do? Like, well, they can do things like affect the renin-angiotensin system, and basically they can end up causing blood pressure to go up, right? More pressure means you're going to be getting more blood flowing to the kidneys, and that can fix the kidneys problems that it's detecting. So if you have someone who has kidney injury to begin with or long-standing kidney disease, this can cause an acute decrease in their kidney function, which is not good. Or if they have something like hypertension, that can be worsened. It can cause fluid retention. So you got to be careful with these cardiac patients who are giving NSAIDs to, because they can have some pretty deleterious effects. So just something to be cautious with. Okay, we'll get more into that, talking about those effects when we talk about cardiology stuff coming up in a few lectures. So anywho, you'll also see that things like ibuprofen and other NSAIDs are going to limit the effect of other antihypertensive drugs. So for instance, things like ACE inhibitors will be less effective. You can see things like bleeding risk because, you know, ibuprofen is going to have sort of a temporary effect on the platelets to prevent them from getting clotting together and causing a clot to form. So you can see some bleeding risk if the patient was on other anticoagulants. So you want to think about these kind of drug interactions that are likely to happen. Some of these we'll talk more about in depth when we get into things like behavioral health or talking about cancer and things like that. So anyway, one thing to note in terms of contraindications, if they have an allergy to aspirin or to ibuprofen, you want to avoid that, obviously. For some patients, this can actually exacerbate their asthma. We're going to get into this in the palm section next, so don't worry about this too much. I'll talk more about that when we're talking about leukotrienes and prostaglandins and whatnot, and what effect that has on the respiratory system there. And then obviously, you know, let them know to worry about signs and symptoms of gastric ulcer disease, peptic ulcers, things like that. And if they have a previous history of that, especially if it was induced by an NSAID, obviously you want to avoid that, right? There's one other one you may find over the counter, which is naproxen or Aleve. Again, all the same things are going to be applying to this. The only difference between the two is naproxen has a longer half-life. You have to give it less frequently. Okay, next we have acetaminophen or Tylenol. And so this is basically, you see the chemical name here. If you ever were curious about where the brand name Tylenol comes from, it actually comes from the name of the chemical. So you can see the Tylenol. You can wow your friends all the cool stuff you're learning in PA school with esoteric facts about drug names. But anyway, so the main difference between Tylenol and your NSAIDs, because they are different, even though a lot of people probably think about their use synonymously, is that whereas the NSAIDs provide antipyretic, analgesic, and anti-inflammatory effects, Tylenol doesn't do the anti-inflammatory component of that, right? It has analgesic and antipyretic effects, but that's it. Because it's kind of working more in the CNS than it is working peripherally. Not really sure why. We don't have the full mechanism for why this occurs. We just know that the drug works. It's relatively safe for the most part. You avoid most of the disease state interactions and drug interactions that we saw with NSAIDs, which means that you can pretty safely give this to the majority of patients you have and not really worry too much about it, with one notable exception. That's going to be for patients who have a history of hepatic disease, hepatitis, if they have chronic alcoholism, things like that. You do really want to be careful there because you can exacerbate that and cause them to develop further hepatic injury. So one of the things you can see there is that we put a max amount that patients should be taking in a day. So for instance, the Great Nepal Dreamer is, but it's an interesting name. But not to exceed something like 4 grams in a day, right? And for some patients, we'll even drop that even lower. So for instance, for some people who are worried about having hepatic dysfunction, we can drop that down to like 3250 in some cases, milligrams in a day. So it really just depends on the situation there. That's what you want to monitor for. But otherwise, it's really safe. And even for some patients who are, self-medicating, we're making the recommendation. If they're having fever, we can actually have them cycle between things like NSAIDs and Tylenol. So for instance, like both of them are dosed Q6 hours most often. And so they could do it something where they would take take a ibuprofen at 9 o'clock, and then at 12 they take Tylenol, and then at 3 p.m. they take ibuprofen again, then at 6 p.m. they take Tylenol. And sometimes that can provide nice kind of consistent levels. That way they don't have like any spikes in their fever. But again, fever is not a bad thing. Fever is our body's natural way of fighting off infection. So just depends on the situation. Okay, let's talk about some systemic antihistamines. This is kind of following along in terms of a lot of over-the-counter stuff we're going to see here is, have you read any studies on Tylenol suppressing emotions? No, but perhaps I've been taking too much Tylenol. Perhaps that would explain my demeanor. That's interesting. I don't know anything about that. I'll have to take a look at that. Anyway, so looking at histamine here, we can see that it's really important for a lot of allergic responses. So for instance, if you have, say you're allergic to pet dander or something like that, and you get it exposed to a cat, you're going to see your mast cells will then start to degranulate, and you're going to have a large histamine response, which causes things like redness due to vasodilation, which can lead to a lot of that edema that happens there as well. Basically, the capillaries get more leaky. So you can end up having a lot of edema happen in those areas. So think about like the eyes, the nose, etc. And some of that flare response you also end up getting with that. So again, and a lot of these effects here are not super comfortable. Have a runny nose, you're all stuffy, you're tearing a lot, and then systemically, you can also see some effects as well. This vasodilation can lead to things like hypotension, if you're having a severe allergic reaction, anaphylactic reaction. You can see things like smooth muscle constriction, where they actually can clamp down on the bronchial smooth muscle, inducing an asthma attack, right? A lot of effects here. We're going to be talking mainly about H1 receptors. There are H2 receptors as well, which are going to be more prominent in the GI effects, and so we're going to look at that when we get to GI later on, but we're going to focus on H1 because this is the most important one for like allergic responses and whatnot, right? So anyway, so what do we see when H1 receptors get activated? We're going to see things like vasodilation due to increase in things like nitric oxide within the cells. You're going to see, this is a big one, mucus secretion between nasal, bronchial, and GI, right? You can see that. You're going to see smooth muscle tone go up, which is important for things like the bronchial smooth muscle, because that if you're closing down on your airway, that's not going to be able to move as much oxygen, which is not great. Bronchoconstriction kind of goes along with that. And you're also going to see the stimulation of the sensory nerve endings, leading to itching and kind of the uncomfortable sort of effect, that pruritus that comes along with that. So what happens when we block those receptors? Well, essentially the opposite, right? So we're going to be decreasing secretion and edema, and the itching goes down, all that good stuff. So this is what we're going to be using our H1 receptor antagonists for primarily. We're also going to see, though, that there are some central effects as well, right? The stuff we were talking about before was just peripheral effects, right? The central effects are pretty interesting, and this is going to apply to what we're going to call the first generation antihistamines. 2 generations we're going to talk about, first and second. The first ones are able to cross into the brain quite easily, so you're going to see more of these central nervous system effects. The second gen do not cross over, and thus they are much less likely to have central effects, or mainly just going to have peripheral effects. Not to say that no one is going to have any CNS effects with the second gen, because some people are more sensitive than others, but certainly it's much less likely. So what are the central effects I'm mentioning here? Sedation is going to be the major one, right? So I'm sure most people have probably taken Benadryl at some point in their life and gotten pretty sleepy off of it. That's a normal effect that we see from the CNS effects of these drugs here. And again, we use that as a therapeutic effect sometimes too, right? So we can actually see it available as an OTC sleep aid. Doxylamine is a first generation antihistamine we can see for that purpose there. Um, and it can be synergistic with other CNS depressants. You don't want to mix it with something like alcohol or benzodiazepines, for instance, or things like that. So you do want to be careful when you're mixing and matching these drugs together. At least warn patients on knowing what to look out for. An interesting effect you can also see is with children. They can actually have what they call a paradoxical reaction, where you give them a dose of Benadryl and you'd expect them to get sleepy. Then they end up having a lot of anxiety. They start to get really anxious. They start bouncing off the walls. They kind of go a little crazy. And that has to do with kind of a unique effect that kids can get with this. Some adults get it too, very rarely, but it can happen. Anyway, some other effects you can see here include some of the antiemetic actions and antimuscarinic actions. This is helpful for things like motion sickness, which you'll see a lot of these agents being used for, and also antimuscarinic effects are helpful for things like secretions and whatnot. It can really help to dry out the patient pretty significantly here. So like dry mouth can cause things like constipation. It can cause urinary retention, things like that, as a result of the antimuscarinic or anti-acetylcholine effects on those muscarinic receptors there, right? What do we see there? Well, basically, as an antiemetic, it's blocking acetylcholine in the CNS, blocking activation of the chemoreceptor trigger zone, and that can lead to strong antiemetic actions here. And in fact, like promethazine or Phenergan actually is one of the most strong antimuscarinic actions you can see there. It's also one of the most sedating that you're going to run into as well. So it could be one of those things where a patient, is going on a cruise and they are worried about being seasick, and so you give them something like Phenergan, but then they can't even stay awake for half the cruise because they're so lethargic from it. So you got to find that balance there between the two in terms of extra CNS side effects plus the actual therapeutic effects you're looking for there. In terms of antimuscarinic actions, that's where we're really going to see mostly a lot of the decrease in nasal and bronchial secretions and things like that. So that's the main effects you're going to run into. And what do we use it for? Allergic reactions, motion sickness, OTC sleep remedies, and we frequently give this as an adjuvant in anaphylaxis or really any allergic reaction. You can help manage that by blocking the histamine of those receptors there. Adverse effects, like we kind of been mentioning, sedation is going to be a big one. Definitely one you want to know. So if you have someone who you're worried about, say driving a truck, and you want to give them something for their allergies, something that's going to cause them to be sedated is not great. So you may want to try something like a second gen agent. It's not going to cause them to be as sleepy, right? As I mentioned, the antimuscarinic actions here, these are also ones I want you to know. So things like blurred vision can happen, urinary retention, constipation's a big one, dry mouth. So again, that's likely to happen as well, which may be a beneficial effect for your patients depending on the situation. And then rarely can you get some hypersensitivity. This is more often seen with like the topical varieties, which I'm not going to mention here too much, but it's more to do with the vehicle than the drug itself. Okay, so this is the important table here of which agents fall into which category. So you should be able to recognize these drugs here and see which ones fall into which category. And you should know that, okay, well, first gen drugs are going to be more likely to cause a lot of the central side effects versus second gen, right? And again, I don't care. Do you know if dihydrogenate is high, medium, or low on the sedative effects? I don't care if you know it's high or medium. I just care that you know that it's going to be sedating because it's a first generation drug here, right? So know all of these are likely to cause sedative effects. They're very likely to cause antiemetic actions, anticholinergic effects, right? That's just generally speaking, all of them are going to do this. You have things like chlorpheniramine, diphenhydramine, and meclizine. These are all going to be over-the-counter varieties you can run into. We still use in the hospital as well. You have things like hydroxyzine and promethazine. Again, I don't care if you know if it's over-the-counter or not. I'm not going to ask you that question on the test. I'm just mentioning it for purposes. For things like motion sickness, are these contraindicated for peds? No, we use antihistamines all the time in pediatric patients. It just depends on the situation. Like I said, that paradoxical reaction is not a guaranteed. It's a rare thing, but it's something you at least want to be aware of. Or if like a parent says, "Oh yeah, my kid goes crazy when they take Benadryl," that's probably why. And it's not. You're like, well, that doesn't make sense. They should get sleepy from it. But no, that they can't have that paradoxical reaction. Right? So there's that. And we have the second generation agents, three main ones, and these are all now over the counter, which is kind of nice. They were all prescription when I was in school, if that shows my age at all. We have things like cetirizine, fexofenadine, and then loratadine. So those are your second generation agents. Very unlikely to cause sedative effects, but if a patient was having motion sickness, these aren't going to be very good for that, right? or if the patient was having, sleep disturbances and you wanted to try an over-the-counter sleep remedy. These are not going to work for that, okay, for the most part. Some patients, will say, oh, well, cetirizine just knocks me out. Maybe that's true, for some people that are a little more sensitive to those effects, but generally speaking, that's unlikely, okay? We also have an intranasal antihistamine, which I'm not going to talk about too much. It's not used very frequently. I didn't even think I took it out of the slides here, so don't worry about this one at all. I'm not going to ask about it. Okay, so let's talk about some corticosteroids. We can see here, I'm going to use the full hour, just FYI, so hope you guys don't mind sticking with me for the full hour. I figure since we lost the hour from the test, but anyway, so let's talk about some nasal corticosteroids. These are beneficial because they work specifically just in the nose, and they limit a lot of the systemic side effects that we would see with using corticosteroids typically, which I'll talk about a few in just a moment here. We have things like beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and then triamcinolone. Some of these probably look familiar from the dermatologic steroids, and that makes sense because they're all basically doing the same thing, and some of them have topical formulations as well. Keep in mind though that there's also inhaled varieties, which we'll talk about during the pulmonology section coming up next. So you don't want to get these mixed up because if a patient doesn't have asthma, they don't really need an inhaled form. It's very easy for people to mix the two up because an inhaler versus a nasal spray sounds like wouldn't be that easy to mix up. But if you look at the names, it's quite simple. So for instance, like fluticasone, Flonase versus Flovent, right? Flonase being the nasal one, and then Flovent being the one you inhale. But if someone is doing a med rec and they weren't being careful and they wrote down fluticasone, you really wouldn't know which one they're talking about, right? So you gotta be specific. Most of these will have the names will be pretty clear about which route it's going to be, so that can kind of clue you in. So for instance, like budesonide nasal is Rhinocort versus budesonide inhaled is Pulmicort. So sometimes they'll try to help you out there in terms of the name. For mometasone, it's like Nasonex for the nasal and Asthmanex for the inhaled form. So don't mix them up because again, they're not going to be doing the same thing because they're only working very locally in whatever tissues that they're in contact with, right? So in terms of their purpose here, we use it for allergic rhinitis and vasomotor rhinitis. The trick with steroids, especially when you're using ones that are very targeted, like the intranasal ones, is you need to use them consistently, and it may be a few weeks before you get full effects, right? Something like antihistamine, it directly blocks the H1 receptor, so it works very quickly. Something like steroids, they have to work in the nucleus, right? Just like any other hormone would. They have to get down to the nucleus, and it takes time for them to really kind of change gene transcription and things like that. So yeah, make sure patients are going to stick with it for a few weeks to see full effects, see if they like it or not. And then the other thing too is that if they stop using it, it's just going to go right back, right? So they need to be consistent about using it there. Side effects are pretty minimal, but you can see some nose bleeding. You can see septum perforation very rarely. This has to do with the wound healing inhibition that happens with steroids, and some unpleasant taste. You see that a lot with nasal sprays because you can get some post-nasal drip, and you can hit that on the back of the tongue, and then you get taste. Now, if you had someone who was having just like typical run-of-the-mill seasonal rhinitis, intranasal steroids are perfect for that. For someone who's having a more systemic sort of allergic reaction, this is where you can get away with using more systemic corticosteroids. They're going to be working system-wide. They're more effective, and they have a stronger anti-inflammatory action when taken systemically, but they're also going to have a lot more side effects. Kind of the downside of using them. But two I'll mention here include dexamethasone and then prednisone and prednisolone we'll talk about in a minute. Really, any of them do the same thing. All of them are going to do the same thing. It's just a matter of like how you dose it and whatnot, and half-life and things like that. But we use it all the time for like drug hypersensitivity reactions or really any allergic reaction here. Now, in terms of their effects, remember that they have both glucocorticoid activity and then mineralocorticoid activity. Glucocorticoid is really the strong anti-inflammatory actions we're looking for. It also has effects on glucose metabolism, which can be a problem for like diabetic patients, for instance. And then you have the mineralocorticoid effects. You think mineral, you think salt. This can have effects on fluids and salt retention in the kidneys. So both of these can happen. These drugs have both effects here, and so that can lead you to know a lot of the side effects that go along with that. So for instance, patients with CHF and hypertension, this can cause fluid retention for them because they're holding on to more fluid in the kidneys. I'll talk more about why that is. It has to do with like aldosterone-like effects. I'll talk about that in the cardio section in a couple weeks. Glucose intolerance too, because of the effects it's going to have on the liver in terms of causing increase gluconeogenesis and glycogenolysis and things like that, right? We're going to see that, if you have like a diabetic patient who's insulin dependent and was taking a corticosteroid, they might have to adjust their insulin doses, right, to account for that. So these are things you have to warn patients about and let them know, hey, if you're monitoring your blood pressure at home, it's going to likely go up while you're taking these drugs here. So things like that. Obviously, we know about the intraocular effects there in terms of causing glaucoma and cataracts and whatnot. And overall, it's going to have a immunosuppressive sort of effect here. Now, is this going to be clinically important if you're taking it for 5 days? Probably not, but for some patients who are taking it for longer, this can be an issue, and that can lead to secondary bacterial infections or viral infections and things like that. Okay. And again, a lot of drug interactions here too. So, for instance, like if a patient's on an antihypertensive, you can see that this is going to make those drugs work less well, right? Or it can decrease the effects of anti-diabetic medications and things like that. So you do want to be careful here. I'll talk about some more of these specific interactions when we talk about those drugs and like endo or in cardio and things like that later on. Okay. Obviously, if they have an already existent fungal infection, you would not want to use these because that would make it even more difficult for your body to fight that off. So that's one relative contraindication there. And then in terms of education, again, let them know, hey, stay away from sick contacts if you can. It does weaken your immune system to some degree. And typically we tell them if you're on it for less than a week, you don't have to worry about tapering the dose of a steroid. If it's more than that, then you need to consider tapering, right? And the reason why that is because when the adrenal glands detect that they have enough corticosteroid effect around, they shut down, right? It's part of the negative feedback loop. The hypothalamus and the pituitary gland turn off basically the need for you to produce any more cortisol. And so if you have someone who's on corticosteroids exogenously for a long time, then their adrenal glands basically just shut down completely. And so when you take that drug away, all of a sudden their adrenal glands don't turn back on just like that. It's not a light switch. And so they can run into adrenal insufficiency, right? So it can have effects on blood sugar and blood pressure and all kinds of bad stuff. So you have to build in a taper for them so that way they taper off of like a week or 2 weeks. So that way it gives them time for the adrenal glands to kick back on. They can supply their own steroids at that point. Prednisone and prednisolone, you might see these. Prednisone being like the tablet form and prednisolone being the liquid form you run into. Same exact effects as you're going to see with dexamethasone. No difference there. The only difference is like the dosing. Dexamethasone happens to be a little more potent and has a longer half-life, but they can be used interchangeably for the most part. No issues with that. Same adverse effects, same drug interaction, so no big differences there. Okay. Now I want to talk about a few ENT decongestions here. So the first one is going to be oxymetazoline or Afrin. Most people have probably seen this over the counter before or may have used it themselves. Basically, this is working as an alpha agonist, which means when used intranasally on the nasal mucosa, causes the alpha-1 receptors to constrict those blood vessels. So by constricting the vessels, that helps to decrease the edema and all the congestion patients are feeling there. So mainly used for nasal congestion. One thing to note with this is that it's really good at what it does, but it can be kind of too good at it. So in basic, what you can see, if patients use it for more than 3 to 5 days, they can have what they call a rebound nasal congestion that happens after they stop using it. So basically what you can see here is with, say someone's using this for like a week straight or 2 weeks straight, their receptors start to downregulate because they're being overstimulated on that nasal mucosa. So they downregulate, so you have fewer receptors available. And then if you take that drug away, all of a sudden you have few receptors available and you're not gonna have enough activation, and so those vessels just dilate crazy. So they dilate open and get even worse congestion than what the patient had before. Something called rhinitis medicamentosa. And it has to do with chronic use of this drug here. So that's why we have a max of 3 to 5 days. Otherwise, if they take it for longer than that, the risk for this goes up pretty significantly. So we say 3 to 5 days. If not, they do use it for longer than that, then they have to build in a taper and come off of it. I've seen some people who have a strong physical dependence on this, and they've been taking it for years in some cases. So not great to do that. Again, why you want to give them proper patient counseling when you see them. Hey, don't use this for longer than that. Again, it mainly just works in the nasal mucosa, but you can see some systemic effects. So if a patient had really bad uncontrolled hypertension, I would probably avoid it in those patients, but this will be relatively safe as compared to some systemic decongestions, as we'll see here in just a moment. And that systemic decongestion is going to be pseudoephedrine or Sudafed. I'm sure most people have probably heard of this one as well. This is, again, another over-the-counter one, but not really over-the-counter, and that's actually behind the counter, and that had to do with a lot of laws that were put into place to curtail clandestine methamphetamine production. Basically, you could use pseudoephedrine as a precursor for producing methamphetamines, which is, if you watch Breaking Bad, you get an idea for how that process goes a little bit there. It was actually quite informative, pretty scientifically accurate. But anyway, so now you can only buy so much, and they keep it in a registry, and you have to go have someone get it from behind a locked box and all this kind of stuff. So it's a big pain, but the drug is still pretty good at what it does. And so again, works systemically to block those or to activate those alpha receptors to cause nasal vessels to constrict, decreasing the congestion. The problem is that because it's systemic, you're going to see that it's working body wide, which means it's not great for someone who has a history of uncontrolled hypertension. Some patients have even stroked out from this before. Headache can happen here, so want to be very careful. This is not something I would want to give to someone who has uncontrolled hypertension or any kind of cardiac disease. I'd be very hesitant to use that, okay? Because it can decrease the effects of their drugs that they're on, or it can potentially cause unsafe, peaks in their blood pressure. Just avoid it for them for the most part, okay? Now, you may see some over-the-counter items that say like Sudafed PE, and that's all just a marketing ploy. Basically, they use the brand name Sudafed and they put the PE after it. It means phenylephrine. Phenylephrine is not very effective at what it does, but they put it there so that way you still see something on the counter and people still pick it up and don't know the difference. Phenylephrine is a really weak vasoconstrictor when taken orally. It's a great drug. IV, has its uses for sure, but over-the-counter varieties are just no good. So if you have a patient who really has bad congestion and they're a good candidate for Sudafed, or that's the only thing that works for them, make sure they're getting the stuff that's behind the counter. Someone actually has to get for them because otherwise the PE stuff is probably not going to work. Okay, and then we have a mucolytic here. So this is one drug called guaifenesin. Mucinex is a common brand name for this. This is a mucolytic and an expectorant. So it basically means if you have a bunch of gunk in the lungs, mucus, this will help to break that up, and it helps to reduce viscosity, and then it will help you cough it up. And so the big thing with this one is just to make sure you tell patients to get plenty of fluids, right? Because you can try to break up that mucus, but if it's all dried out because the patient is dehydrated, it's not really going to do a whole lot of good for them. And then let them know they are going to have increased drainage because this is going to break that up, and they'll have that urge to cough it up. So it can be useful for that, but again, not the most effective drug out there I've ever seen, but also relatively safe. Not a ton of side effects associated with it. So pretty benign for the most part. And of course, if things are not improving after 7 days or so, then definitely have them follow up because there could be something else going on. It could be pneumonia sitting there. Who could say, right? But anyway, all right. So I'm about 7 minutes early, so that's good. So I finished up this first section. Let's see if you have any questions. Let's see. Oh, someone posted me a link here. This is one of the articles about Tylenol suppressing mood, specifically dulling emotion, pain from social exclusion. Interesting. I could probably use some of that, especially after COVID, right? We're all being kind of socially excluded from one another. I'll have to check that out later. It's interesting. Thank you for sharing that. What other questions do you guys have? Again, I'll have to take a look at the test and the stats and whatnot, and then I'll figure out if there's any givebacks. And then I'll post an announcement about any high misses or concepts I'd like to clarify for you guys. So otherwise, if not, then you are free to go. I hope you have a great weekend, and I will see you next week. Thank you for joining me. I appreciate it. You guys have a great day. I'm going to go ahead and end the stream to see if there's any questions. I will see you all later.